I'm Peggy O'Kane, President of NCQA. When I founded NCQA 35 years ago, I dedicated myself to improving healthcare. We've made a lot of progress, but as I prepare to leave NCQA, I feel there's unfinished business. Dynamic organizations lead the way with bold approaches and new technology, but structural problems hold us back and hurt us. Fee-for-service fragmented care, a lack of respect for primary care, these all make healthcare worse and more expensive than it should be. We need new ways of thinking, and that's where this podcast series comes in. I'll be talking with some of healthcare's brightest thinkers, executives, researchers, and innovators working for real change. We'll explore the promise of new technology and the revitalization of primary care, and how we can deliver real value for every patient. These conversations are for people who are curious and to want to help the U.S. escape bad health outcomes and runaway costs. Let's explore the future together. This is Quality Talks. Sachin Jain is our guest today. Sachin and I have known each other for a very long time. I think I met you when you were at HICFA or CMS, I guess it was at that point.
I think it was ONC actually. When I was working as a special assistant to David Blumenthal when he was leading the Office of the National Coordinator.
Yeah. So Sachin's had an amazing career in healthcare, and he's an amazing leader today of SCAN Health Plan. May I say that we have a friend in common, Leva Lesson, who was the CEO of CareMore Health Plan. She's no longer with us, and I think we both appreciate being mentored by her and being inspired by her vision for healthcare.
I mean, Leva Lesson, in a land of, kind of impressive and innovative healthcare leaders, I think Leva Lesson was a shoulder above the rest. She had a special way about her, a crispness in communication that I think was unrivaled, and a combination of intellect and humanity that I just haven't really found in almost anyone else who works in our industry. Her ability to connect the dots between culture and performance and results is unlike anyone else. And I was very lucky that Leva found me and brought me to CareMore at a very, kind of pivotal and critical point in my career where, I barely knew what Medicare Advantage was. I've now spent the better part of the last decade working in the program. And I'm just blessed that I was able to learn it from one of our industry's greats. And she also, I think gave me an incredible opportunity to succeed her as the leader of CareMore, which for those of you who don't know it, was really kind of the original integrated payer provider in the Medicare Advantage space that really focused on high-risk patient management as a means of managing medical costs and improving outcomes. Lots of the companies that are celebrated today in this space drew their inspiration from CareMore. And, and I'm talking about the Oak Streets and the ChenMeds and the Landmarks. And many of them are actually populated by CareMore alumni, either from Leva's generation of alumni or my own generation. So I think it was just a very impactful organization. It's since been renamed. It's changed ownership a couple of times. But I think the impact of Leva and CareMore just extends, very far beyond.
Yeah, she just left an incredible legacy. And I think, providing care for the elderly is not like providing care for younger populations or where people are well. And I think that was the magic that she really invented. And so it's a nice way to start this because we're both inspired by her. And the system itself needs to do better, according to her vision, actually. Quality, affordable health care and compassionate care for the elderly. So our question today is, why isn't healthcare better at getting better? My career is explicitly in quality. Your career is, quality is right up there in terms of what you have to be paying attention to. And it's been 24 years since crossing the quality chasm. And where are we?
So, Peggy, one of my earliest mentors was a public policy professor named Deborah Stone. And Deborah actually taught me this very important maxim drawn from John Kingdon's work in public policy, which is how you define a problem really influences how you solve a problem. And I think if I had to be really blunt about it, we don't speak about healthcare in plain enough terms. And I think the quality improvement movement has been shrouded in measurement and self celebration. And we're not necessarily taking a hard enough look at what is and what isn't. And the truth is that, we may have improved lots of metrics over the last 2 decades, and we should certainly take a bow for that. But the reality is, there's people in my life today who are avoiding accessing care because they don't know what bill they're going to get on the other side of it. There's people who need primary care appointments who can't get them until October. There are people right now who have cancer diagnoses who are getting the wrong treatment because they're being sorted into the wrong type of care or the wrong type of provider. We have an incredible labor arbitrage problem where we've got, work that traditionally sat with doctors that's going to nurse practitioners, work that traditionally went to nurse practitioners is going to nurses, work that's going to nurses is going to community health workers, and work that used to go to community health workers is now going to lay people, because everyone is trying to squeeze out a penny out of every single interaction in American healthcare. And frankly, when you engage in this kind of real talk, some people get offended because it offends their view that things are actually better than they are. But come out of your office on the seventh floor of your office building and walk into the tower where people are actually getting care, or go talk to some of your friends who are doctors or nurses, and you realize we're embattled right now. And unless we actually say out loud that we're embattled, we're never going to start to think about the more transformative solutions to the kinds of problems that we actually have. Talking about Liba used to say, you can't change without changing. And the truth is, in healthcare, everyone wants everything to get better without changing a darn thing. It's what I have crystallized as the leadership crisis in American healthcare, because ultimately things aren't going to get better until we actually call them what they are, and call our baby ugly. And our baby is really, really, really ugly. And doesn't mean that, can't grow up to be a beautiful person. But for now, we have to just be very clear about, what it is that's happening right now.
How do we start that reset, Sachin?
So I think we have to get out of this cycle of toxic positivity. I think a lot of people in healthcare feel an obligation to be on a podcast like this one and repeat, industry prattle about triple aim, quadruple aims, and now I think there's a quintuple aim. People feel a need to, talk about things in terms of data. People feel a need to be very careful in talking about the companies that their friends may be operating. But the truth is we've all been complicit in something that's not been getting any better. I would just tell you that I think we need to have the hard, honest conversations that can then lead to the kinds of progress. And unfortunately, what's happened is we've all become too captive to our industry talking points. And with those talking points is a lot of finger pointing and deflection. And the finger pointing and deflection goes something like this. The insurance companies blame the doctors blame the government blames the pharma companies, blame the NIH, round and round and round we go. Instead of saying, I run a company of some scale. I run a managed care company. We have 300,000 Medicare beneficiaries. What are the things I can do today to actually make things better? How do I deny fewer claims? How do I increase access to primary care? How do I get more specialists in my network? How do I, reduce copays for people so that they actually feel like they have first dollar coverage? If we all just took care of our own part of the ecosystem, we'd get 20, 30% better. But instead, most industry talking points are about, hey, we don't get paid enough for what we do. Everyone who's making money claims that they're losing money on X, Y, or Z lines of business. Everyone complains about regulatory capture. So there's just a bit of like having normalized the abnormal. And I think that that's the thing we have to undo if we're going to actually make the kinds of forward progress that we're hoping to make as an industry.
Yeah, that image of people pointing to each other reminds me, there was somebody that coined the term the circle of unaccountability, and it's like everybody pointing at everybody else. It's so true.
I mean, Peggy, one of the
Uh,
first places you and I spent time together was actually the ABIM Foundation meeting
right.
years ago, right? With our friend Bernie Rossoff and others who we love and cherish. The reality is when I first went to that meeting, I was like, oh my God, I've arrived at the Super Bowl. I mean, it was the heads of all the medical schools, all the professional associations, all the professional societies, all the government agencies, the journals. I mean, that meeting is kind of like, they called it Davos for healthcare for a while. And, when I first went there, I thought, wow, these are the people who can change everything. 10 years later, you look around and you're like, are we the reason nothing's changing? In part because I think we've lulled ourselves into a sense of incrementalism in this industry, that getting 1 to 2% better is good enough. And the truth is the incrementalism is what is holding us like back. It's the fact that we think we can take years and years and years to pilot something that's actually common sense to make a difference, as opposed to just doing it. And again, I know I sound a little bit crazy in the land of kind of like peacetime healthcare leaders, but I personally think like we're at war and we need more wartime healthcare leaders who are like, hey, we need to change things. The problem is that in many organizations, the so-called wartime people get marginalized. They get seen as the people who are upstarts, who aren't team players because they're not adapting and evolving. But again, I think part of that is we don't necessarily have enough support for the revolutionary energy because we're so focused on evolution as opposed to revolution. And people are worried about breaking things. Well, I have a memo to all those people. Things are mostly broken as they are right now. So this fear of not breaking things is just fundamentally a defensive posture that we've adopted in our industry. And I think we need to adopt a more offensive posture.
So you've written about misplaced nostalgia for traditional Medicare. What do you mean by that?
There's a lot of people out there who are very focused on traditional Medicare, being a superior program to Medicare Advantage. And I'm going to declare my biases. I've spent the last 10 years, working in Medicare Advantage, and I make my income from Medicare Advantage. So I want to make sure I say out loud my conflict of interest here. But what is incontrovertible when you look at traditional Medicare versus Medicare Advantage is that traditional Medicare is a rich person's Medicare program. Period, full stop. When you look at what's covered and what's not covered, dental, vision, audiology, no coverage in traditional Medicare. You want wide access to a broad network? Great. You have that in traditional Medicare, but you also have a lot of exposure for copays and coinsurance. You're on the hook for a Part B premium, which is $174 a month, or actually it's now updated to $184 a month for this year. You're on the hook for a Part D premium, which will cover your prescription drugs. And then if you want full coverage, you've actually got to purchase a supplemental policy on top of that. And all of that adds up to about $1,000 a month for a couple who's on traditional Medicare. If you look at the average income of a retired couple, they're at about $54,000 in this country. Now imagine that you've paid your entire life, your Medicare taxes, you've paid into the system, all with the right to be able to pay $1,000 a month at the end of it to, to get your full coverage. So $12,000 a year is the price of full coverage in traditional Medicare as a retiree. Now contrast that with in LA County, there's many companies, not just mine, that offer zero premium plans. You have to still pay your Part B premium, $184 a month, but then you also then get your Part D covered. You also get a lot of coverage, zero copay for your primary care, zero copay for specialist appointments. Sure, you have to operate with an HMO, with a network. There's prior authorization that you have to contend with. You also get supplemental benefits. And the truth is that it is a very good program for lower income or middle income seniors. And that's the reason that Medicare Advantage is now a majority program among Medicare beneficiaries. That's the reason I say, that people have misplaced nostalgia for traditional Medicare, because I don't think people really recognize how much it actually costs. And what I would tell you is that Medicare Advantage does cost more. There's a lot of opportunities to fix Medicare Advantage, but the overall framework that Medicare Advantage, which is a full coverage framework, which is in some markets, many markets, a zero copay framework, and it's frankly just a more affordable way of accessing care, is better. Now, here's what I'll say about that. I'm totally open to a full reform of the whole Medicare system, because I do think it is broken. I think we need to really look at the whole thing from the studs up and fix it. But there's problems on both sides. And I think there's a lot of people talking about the problems of Medicare Advantage, not a lot of people talking about the problems of traditional Medicare. I think the opportunity here is to build new and different care models that people actually want to have access to and that you can't access through other means. The reality, though, is that I think we the failure of the Medicare Advantage model over the last, several decades, and I say this at every industry meeting that I go to, is that we have not proven beyond a shadow of a doubt that we are better than traditional Medicare. There's papers that say
Right.
one thing, there's papers that say another thing. Our opportunity these last few decades, the opportunity that we missed was the opportunity to demonstrate clear, absolute superiority. And, I think we have to have options that work for everybody.
So I'm going to challenge you a little bit on this because I mean, you know what goes on in traditional Medicare. And, I remember when there was a care management demonstration, that was even before you were there, where they found all these people with end stage diabetes who haven't seen a doctor in 4 years. And, there's also like a chaos factor where people are bouncing around the system and so on. Unfortunately, I think Americans tend to think if it costs more, it must be better.
Sure.
So I think that this sells the potential of Medicare Advantage short in some
Well, no.
ways.
So look, I want to be balanced here, and I don't want to be kind of an industry apologist because there are certainly problems with Medicare Advantage. But you're right. I mean, there's not a lot of quote unquote management of people's care in the traditional program. In Medicare Advantage, you're assigned a primary care doctor as part of your enrollment in the plan. There's a lot of focus on making sure that people get their preventative screenings, and that getting them plugged into care actually means that there's higher levels of care coordination. And in the traditional Medicare program, there's underutilization. There's also overutilization. And, in the fee for service model, which people have nostalgia for, ends up, also being a blank check. And again, there's a lot of overutilization that ends up happening. And I don't mean it as nefarious overutilization because, I think most doctors and hospitals have very good intentions for patients. But if there's a soft indication for something and you're going to get paid for it, why not do it? And that's usually the mentality that exists. And sometimes there's real downsides to actually doing things. That unnecessary, CT scan may reveal an incidentaloma that leads you down a path of biopsies that results in complications that you don't necessarily need to have, or that extra echo that you get every quarter may not hurt you, but it pulls money out of your pocket. And so again, those are the kinds of things that I think don't get talked about when people are talking about traditional Medicare. And they say, oh, well, like, ACOs can fix that. ACOs maybe fix it from a total system cost, but do very little for beneficiary costs. ACOs don't create any less exposure for people for their own costs, even if they reduce total expenditure. So I think that that's just an untold part of the traditional Medicare ACO story.
Very interesting. So let's talk about the STARS program. So you're famous for having sued about a star rating that really made a material difference to your organization. You want to tell us about that a little bit?
Or so a couple of years ago, we were projecting to have 4 stars in our biggest contract. And at the time, when the star ratings were released, we were found to have a 3.5 star rating. And the swing in payments, for those of you who are not close to this, is about $250 million in a plan of the size of ours, which is about 280,000 members at the time. And that $250 million isn't money that goes into our pockets. That goes to our providers and our risk-based contracts, as well as to our beneficiaries in the form of richer benefits. So this was a very significant amount that we were kind of like at risk for. And so we started looking at our data because our raw score was 3.73 or 3.74. And we found two irregularities actually when we started looking more closely at the data. One is that there was a French foreign language phone call that was, with a secret shopper. And there's one of the star measures is around timely response to a foreign language phone call. And the call was a bit ambiguously delivered and answered. I mean, the way the person asked questions created confusion, and the call went on longer than we thought it would have, and we missed the cutoff by about 34 seconds. So, if CMS had thrown that call out of the sample, we would have been above the 3.74 threshold. It would have been 3.83 would have been our score. So we appealed to have this call removed from the sample because there was ambiguity about whether this call was answered timely or not, or whether there was errors in the ways that the secret shopper approached our call center. The second thing we discovered is that CMS had implemented the Tukey outlier methodology without actually having published doing this in the Federal Register. So in essence, it had acted outside of its authorities to implement a new methodology for actually pulling outliers, determining the cut points for the different star measures. And we basically went to the highest levels of CMS. We went to 5 different levels of appeal. And, essentially we're told we're sympathetic, but there's nothing we can do to change this. And, we felt like our members had been wronged, and we felt like our providers had been wronged, and we felt like we'd been wronged. And so took this really unprecedented step of actually, approaching our board about, hey, I think we should take some legal action against CMS on this issue. And so they didn't say, hey, you should sue CMS. They said, Sachin, you can make the decision. That was how it came back to me. So it still sat with me. But I felt like it was the right thing to do. The judge had decided that it had not ruled on the French foreign language phone call issue, but had ruled on the Tukey outlier issue and said that CMS did, in fact, act outside of its authority. And as a result, the whole industry's star ratings were recalculated. So over $1 billion in payments, 1.3 million beneficiaries were impacted, 60 different plans had their star ratings, recalculated. So in a funny way, this may be the most impactful thing I've ever done in my career in terms of broad scale impact, because a lot of people's benefits were a lot better. But I think the bigger point, Peggy, that I think is worth thinking about is how these like small differences in measures actually result in huge differences for the health systems and health plans. And I don't think that this is what was intended when we actually built the star rating system. I don't think we were looking for a single phone call to be a cliff vest between a $250 million payment or not. So I think it prompts this question of like, are we measuring the right things? Is, Scan's ability to answer a French phone call in a timely manner a good measure in a geography where we don't really have many French beneficiaries? Or should we try to simplify the system? I think, Peggy, one of the biggest challenges that we have is we've built this, measurement industrial complex in healthcare where we're measuring a lot of things, many things that don't actually matter. And the question is could we simplify things for the benefit of patients and for the benefit of clinicians, and really zero in on 3 or 4 things that really move the needle, as opposed to creating the administrative bloat that we've actually created in healthcare because we've introduced so many different payment programs and measurement programs.
Yeah, I actually agree with you about that. I think one question I want to ask you is there a way to kind of do this analysis so that people are not chasing that last point?
Companies that are chasing people, many of whom, may not even qualify for it or may have a contraindication. There's a measure of statins for patients with high LDL. If you've had a bad reaction to statins, getting you extracted from the denominator, good luck.
Yeah.
That's the kind of thing that we've actually created. I'm of two minds about this. I think measurement is important. Let's not ignore that. Measurement is important. At the same time, I think it was Saint Exupéry who said that which is essential is invisible to the eyes. He wrote that in A Little Prince. And I think in healthcare, we focus so much on what's visible to the eyes that we ignore the things that are invisible to the eyes. And I
Yeah.
think it's what's invisible to the eyes is, the human connection that people have with their patients. The other framework I think about is the Heisenberg's uncertainty principle, like the very act of measuring something changes something. And what
Yeah.
we've done is we've actually changed the clinical interactions by focusing so much on measurement and widgets and performance management. And I think that's why we have a nation of aggrieved doctors and nurses, who are crying for something different, but they
Yeah.
don't even know what anymore.
But what are the 3 or 4 things that you would like to see the STARS program focus on?
Well, I think experience is really important. I think patient member satisfaction should be front and center. I think in this era where people are experiencing a lot of utilization management, I think we should be looking at friction with your plan and whether or not it's easy to get the care that you actually need. And then I think we should, at any given time, pick 2 or 3 conditions that, whether it's diabetes or cancer care, and really just focus on like, are we excelling at the basics there? Do people have access to an NCI designated comprehensive cancer center where we know outcomes are better? Do people who have diabetes get the basics and get them most of the time? And I think just focusing on a few things, in part, goes back to this idea that how you do one thing is how you do everything. If an organization can be really, really successful at a few things, chances are they're doing the other things, mostly well as well. So that's my view of it. But I do think that one of the challenges we've had is we've created so many different ratings and ranking schemes that everyone is
Yeah.
excellent at something. And the truth is that there's just a lack of focus on the things that matter most to people and patients and communities. I also think there should just be more transparency around cost. One of the things I love about MA is that we do have a maximum amount of pocket measure, which actually gives you a lot of transparency into what your total cost exposure could be over the course of a year. And I think we need more of that. We need things to be simpler. Honestly, CMS could do the world, lots of favors by simplifying provider directory data, which right now they're measuring each plan on. It's creating lots of burdens on the health system. So again, I think going back to the start of this podcast, we've convinced ourselves that a lot of things that we do make a difference because we're not having honest conversations with ourselves about whether they actually make a difference. We have opportunities to radically simplify things for people, but for whatever reason, we mushroom in our complexity. And so again, I think that's the work of the next couple of years is to really think about how do we integrate more care? How do we create more access? How do we create more competition among entities? And frankly, one of our biggest challenges is we've had poor antitrust enforcement over the last number of years. So we don't, so competition is going down as opposed to up. And I think people feel more lost today accessing healthcare than they did 20 years ago, even though we have more data and even though, there's been a lot of clinical innovation over that
Totally
time.
agree. Totally agree. So if someone were to give you the proverbial magic wand and we were all honest about what we could do better, what would you do? Where would you start?
So, I was a student of Michael Porter's and I was one of his first RAs in his kind of healthcare scheme. And I think Michael took us in a lot of misdirections. But I would say the place where Michael got it right actually comes from his non-healthcare work, which was all focused on competition. Competition makes everything and everyone better 100% of the time if it's done right. And I think we have to reset the competitive framework for American healthcare. That's going to require antitrust enforcement so that there are still organizations that we're not all under one one large national carrier, but that we actually have lots and lots of carriers who are integrated and partnered with health systems and are competing for patients the good old fashioned way by being actually excellent and having the words on the wall at these systems and organizations actually mean something. So instead of just being, traditional corporate pablum or prattle. So that's my view of it is value-based healthcare only works when there's real competition. Otherwise, it's just a cute industry buzz term.
Those seem like good words to end on. I want to thank you for a really bracing conversation. Really great. Thank you so
Thank
much.
you. Yeah, really appreciate it, Peggy. Great to be with you.
Dr. Sachin Jain was the perfect person to kick off this podcast series. It's easy to get lost in the weeds of incremental improvement, but Sachin's examples of patients who struggle with access and affordability inspire us to think bigger. His central point about stagnation in healthcare resonates with me. I appreciate his push to have candid conversations and to embrace real change rather than minor refinements. I think he's right that our problems demand a significant shift. Sachin makes a strong case that what he calls the measurement industrial complex needs to simplify measurement and concentrate on what matters most. His suggestion to focus on vital areas such as access, patient experience, and cost transparency is a valuable set of thoughts. Sachin also offers a compelling perspective on Medicare. He challenges conventional views of traditional Medicare, arguing it's expensive, doesn't cover very much, and is mostly for wealthy people. In contrast, he makes a strong case that Medicare Advantage, despite its imperfections, has broader coverage and is often more affordable, benefiting more people. And yet, those imperfections need to continue to be a focus, both for MA plans and for CMS and us. This conversation should give all of us a lot to consider about how we can make healthcare better. I feel confident about the future of quality, knowing that leaders like Sachin bring such conviction and clarity to the mission. I thank Sachin for sharing his candid and constructive perspective. And thank you for listening. Thank you for joining us this time on Quality Talks. If you enjoyed this podcast, please rate us 5 stars wherever you listen. We'll see you again next time.